Hello friends, as we know that we are participating in the 12-week certificate course on palliative care with integrative approach, and you know, we have discussed the primary goal of palliative care in earlier lectures. But once you go to the patient as a member of a palliative care team, then how you should communicate, how you should initiate the communication, that is very important. In the communication, there are two important factors. First of all, patient listening. You should have a quality to listen the patient, because patient is already under distress. He is facing a lot of problems. He has lost the hope for life. Quality of life has been compromised because the treatment, main line of treatment is not effective in his case. Then what to do? We have to be very careful in communication. Communication is an art. Many people having personality of extrovert personality, they can talk to any person anywhere, and they can raise many issues of the interest to both the dialogue participants. But some people are introverts. Suppose your patient is an introvert, he is not able to talk to you, he is not willing to talk to you. What you will do? So you have to have some kind of skill. And today in this talk, we are going to discuss about those skills which will help you in communicating with your patient. Symptom management in palliative care. First of all, I am repeating it just to make it a revision for you. Cognitive symptom. Manage confusion, agitation, and memory loss using non-pharmacological and pharmacological interventions. Second, physical symptom. Address pain, which is very common in this kind of patient. Address constipation, address loss of appetite, and address sleep disturbance. I have told you in the beginning that there are three pillars of good health: Ahar, Nidra, and Brahmacharya. Ahar means diet, Nidra means sleep quality, and Brahmacharya means physical activity and code of conduct. They are the three basic pillars of good health as per Ayurveda. Here also, in the modern medicine also, physical symptoms they have mentioned here, which is very common to the Ayurvedic concept. Pain is additional to it. Constipation is linked to loss of appetite and sleep disturbance. So all the three things are related. Even pain is also related to disturbed sleep and disturbed digestive system. And psychiatric symptoms. Manage depression, anxiety, delusions, and hallucinations if present. It means the take-home message is one needs to communicate with patients on these issues, three issues. What is the cognitive symptom, what is the physical symptom, and what is the psychiatric symptom. So communication in palliative care, the goal is build trust and rapport with the patient. First of all, build trust. Patient should feel that you have come here to help him. You have not come here to treat him. You have come here to help the way he wants. The dignity of the patient has to be considered by you as a first step. Second thing, understand patient value and preference. Build trust and rapport to understand the patient value and preferences. And then deliver compassionate, clear information. The trust will be built when you will give compassionate and clear information about him, about his disease, about his family members, financial burden, everything what he wants to know. Honest information, clear information has to be given. Then he will develop a trust between you, and then he will listen to you. So communication is very important. The key principle is honesty, number one. Honesty. Number two, empathy. Number 3, clarity. Number 3, patient-centered services. So 4 things you have to talk to your patient during communication. So barriers in communication and how to address. What are the barriers? Emotional discomfort, number 1. Time constraints, number 2. Language and cultural differences, and lack of training. You are not properly trained to communicate, you cannot do very good with your patient. Language, if you don't know the language, the patient understand, and cultural difference is there, you are not able to communicate. And time constraint, if you are not giving time to your patient, nothing will happen. And emotional discomfort, this is the most important. Now, the spikes protocol is very common. This is applied for communication. I will discuss it in the last slide, but here I am introducing you the spike, like setting, S for setting, P for perception, I for invitation, K for knowledge, E for empathy, and S for strategy. SPIKES. 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 This is a tool. So, active listening. What is active listening? Non-verbal cues, reflective response, and open-ended question. There are 3 methods for active listening. I am describing it, all the 3 one by one, so that you can, with example also. So, non-verbal cue means body language, facial expression, gesture, posture, and eye contact. Communicate feeling without words. Non-verbal means communication without using words. How you will do it? By the body language, by facial expression, by gesture, by posture, and eye contact. For example, nodding, smiling, leaning forward, yes, I understand, maintaining eye contact. These are the examples of non-verbal cues. Reflective responses means techniques when listener repeats or paraphrases the speaker's thought, showing that he is understood. I mean, you repeat the thing, the same thing he has told. Yes, I understand what you are telling. You tell like that. It should be like you felt, it sounds like you felt frustrated when that happened. Is that because he is complaining something? So you have to support his view by reflecting. An open-ended question. Questions that encourage detailed response rather than yes or no. But you want your patient to open, to tell as much as he can, not only in short yes or no. So ask in open-ended questions so that he can answer. Can you tell me, for example, this example, can you tell me more about what happened on that day when you had a heart attack or something, some problem? How did that make you feel? Then he will speak something. Then this is active listening. Now, role of empathy, validating emotions, offering presence over solutions, and non-judgmental support. This is the empathy. Empathic skill, validating emotions, offering presence over solutions, and non-judgmental support. These are the 3 things I have told you, empathy. I am defining it now. What is validating emotion? Acknowledge and affirm the patient's feeling without minimizing them. Give them full strength of listening and acknowledge what they are saying. For example, it is completely understandable to feel overwhelmed right now. Offering persons over solutions. Focus on simply being there, not fixing everything immediately. You are just giving him a company, give him a feeling that you cannot treat him. I am just here to accompany you, to listen to you, to talk to you. This kind of feeling. Offering presence over solutions. You are not solving the problem, but you are just showing your presence so that he feel confident. Sitting quietly and listening attentively without rushing to offer advice. Don't give undue advice because you know you cannot treat him. why to give advice. And non-judgmental means accept the patient experiences and response without criticism. You are doing your best in a very difficult situation. There is no right or wrong why you feel. You are doing it at your best. This kind of communication will help patient that look, my patient palliative caregiver is giving me importance. This kind of feeling will come. Then communicating prognosis, disease prognosis now, being realistic but hopeful, tailoring information to patients' readiness and avoiding medical jargon. These are examples, being realistic but hopeful, acknowledging the seriousness of the situation while supporting a positive outlook. You know that disease is very serious, it cannot be treated. Acknowledge this seriousness, being realistic. The treatment may not cure the disease, but it can help improve your quality of life. Don't you agree with me? You have to tell your patient. If he says, yes, I can understand, then he will start communicating with you. Tailoring information, adjusting the amount and depth of information based on what the patient is ready to hear. Unnecessarily don't load with information. Suppose I have talked about heart disease, I have told you many things about heart failure. But in a palliative care, since you are under training, you should know. But if a palliative care patient is there, why he is interested in knowing all these things? He is interested in knowing how his constipation will be removed, how his hunger will be revived, how his sleep quality will be improved. These are his problems, right? Similarly, so patient listening is very important. Would you like me to explain all the options now for improving your quality of life, or focus on just the immediate next step? Ask him. If the patient says, look, I want immediate relief, then only talk about immediate relief. Don't talk about the future plan. Maybe sometime next, when he is mentally prepared to listen to you, then you talk. And avoiding using simple, clear language instead of technical terms. Instead of using the word metastasis, say the cancer is spreading to other parts of your body. Cancer is metastasis means when a cancer moves from one tissue to another in your body, it spreads all over the body. So patient may not understand metastasis, it's a medical terminology, but you explain him like that. The advanced care planning for cancer patient, discussing goals of care, end of life preferences, living will and DNR orders. Discussing goals of care means conversation about what outcomes are most important to the patients. For example, would you prefer treatment that extends life as much as possible or focus on comfort? This is discussion goal. End of life preferences means understanding the patient's wishes about how they want to spend their final days. Some people say, look, I don't want to go to ICU. I want to live with my family members. Talk to them, discuss with them. Do you wish to spend your remaining time at home or in a hospice setting? Hospice setting means a special center where these kind of people go and live for some time and they die. Yes, but most of the people don't want to go to hospice. They want to remain in the home where they have lived their whole life. Ask with them, discuss with them, and then follow. And living will, legal documentation outline the type of care desired if the patient cannot decide later. I mean, suppose the patient is today conscious and tomorrow he goes to ICU, he becomes unconscious. Then who is going to take decision? He has to write a will. Legal document has to be prepared. Would you like to complete a DNR form in case your heart stops during treatment? If you say yes, then go ahead, follow it and do it. Advanced care planning. This is the advanced care planning for cancer patients. Now, advanced care planning for stroke patients. Discussing goal of care, aligning medical interventions with functional goals. If recovery is limited, would you want continued aggressive treatment or comfort care? If recovery is not there, would you like to continue with the medication, or you want to stop it and go only for comfort care? End of life. Decision about preferred care setting and life-sustaining treatments. If you cannot speak or move again, how would you like us to proceed with feeding or care? End of life preferences. Ask the patient, advanced care planning. And living will, instruction about treatment preferences in case of incapacitation. Would you like to have CPR or intubation like the ICU services? If another stroke leads to coma, he has to say yes or no. So these are the kind of communication you have to establish with the patient, and you have to get his legal consent. And involving family in communication. This is also very important because most of the time the palliative care team includes the family members, patient, and the health support system. So decisions should also be collective. Addressing caregiver stress. Caregiver is also under stress. Are you addressing it? Clear role and expectation. Shared decision making. Addressing caregiver stress means recognizing and supporting the emotional, physical toll on family caregiver. This is the addressing the caregiver. What do you mean by caregiver? Addressing means recognize the problem with the family members. You have been caring your mother day and night. Would you like help from a support service? Ask them, because they are also under stress. They should be released. Clear roles and expectation. Defining what each family member is responsible for in caregiving and decision making. Suppose there are 5 family members living with the patient. If everybody takes some responsibility of some work, then there will be no burden in the family, and the patient will also be happy. But if everybody is sitting and only one person is taking care of all the aspects of the patient, then he may get tired. Let us decide who will handle medication, who will handle the doctor's visit, who will handle the daily care, so on. Like this management among the family members, after thorough discussion, communication, will make the family caregiver at ease, and shared decision making, including family in health decision. Family members should be included in the health decision while respecting the patient preference. Suppose the patient want to write a will that he don't want to go for like this DNR orders here, he want to write DNR order. But for that, make the shared decision with the family member. Let us sit together and talk through the treatment options so we can agree on the next step. This is very important. Now, cultural sensitivity in communication. In cancer patient scenario, respecting belief about illness and death involving cultural mediators. Components, what are the components? Application, real life scenario and example. Respecting belief about illness and death. Understand and honor cultural and religious interpretations of illness, healing, and end of life. The patient believes that speaking about death invites bad luck. The team avoids directly saying, "You are dying." The team will say, use terms like serious illness and focus on the comfort care. This example I am giving you. So, if your patient is a cancer patient, then how cultural sensitivity can be addressed. Involving cultural mediators, using interpreters or community leaders to bridge gap in understanding or to support decision-based cultural values. Team invites a spiritual leader, familiar with the patient's cultural background, to facilitate the conversation about hospice care. This is the very important part. Cultural sensitivity of the patient has to be taken care. Managing emotional reactions. Next part I told you, emotional reaction. Practical tip for cancer patients. Suppose your patient is a cancer patient. How you manage the emotional reactions. Handling anger, denial and grief, self-awareness and professional boundaries. What is anger? A practical tip: acknowledge the emotion without personalizing it. Stay calm, listen, and empathetically. Example: I can see you are angry. This situation is incredibly hard. Let us talk about what is frustrating you. Denial: do not force confrontation with reality. Respect defense mechanism, but gently guide them. Example: it is okay to hope for the best. We are also here to help you live as comfortably as possible. Denial: you are denying that you are not going to be cured, but how you are speaking to him, that is very important. This is the art of communication, I want to tell you, all the students. Grief and sadness: validate feeling without rushing the person, allow silence and other emotional presence. Sitting quietly while the patient cries, then say, you are not alone in this situation. We all are with you. So this grief and sadness can be addressed by this kind of communication. Self-awareness: monitor your own triggers and reactions. Use peer debriefing or supervision regularly. A nurse speaks with colleagues after feeling overwhelmed by a family's emotional burst. Self-awareness. And professional boundaries: avoid over-promising or becoming overly involved. Refer to counselors when needed. You don't do it, call a counselor and let him talk. Call a spiritual guru and let him talk. Because professional boundaries, you are a palliative care giver. You are not a counselor. You are not a... In your team, there are many people, but if you feel that he should be invited, other member of the team, you invite him. The doctor refers the patient daughter to a psychologist when seeks constant reassurance. So now, beginning I told you the spike protocol, I am just explaining you. Setting up means ensure privacy, involve significant others, sit down, minimize interpretation. Can we talk in a quiet place where we won't be disturbed? This is a setting the position of discussion, communication. P, perception. Assess the patient's understanding of situation. What have you understood about your illness so far? This is the perception of the patient. I, invitation. Ask how much the patient wants to know. Would you like to explain all the details or just the overall picture of your disease? Invitation. You invite him. If he says yes or no, acknowledge. Give information clearly. Avoid jargon. So go slowly. The scan shows the cancer has progressed despite treatment. It means your treatment is not working, your therapeutic response is very poor, but you cannot say it directly. Say like the indirect way. Empathy: acknowledge and validate emotions. I can see this is very difficult news to hear. But I am here with you all the time. Don't worry. This empathy you should give. And strategy and summary. Discuss next step. Ensure understanding. Let us talk about what we can do now to manage your comfort and support when we know that your disease is spreading, treatment is not effective. All these things we know now. Now what to do next? Discuss with him. So conclusion and takeaway of this part of communication is a clinical skill. Communication is a clinical skill. Its keys are practice, empathy, and feedback. And every interaction counts in palliative care. So friends, communication skill is very important part of your training. And we are giving you some real scenario questions. You have to answer them in your Google Classroom. And if you get a chance, to deal with some of the patients in your locality who needs palliative care. Go and discuss with them. Apply the spike tool and make a note of it. Okay, how you have communicated with him and how he has responded to you. If these things you do in practical, in true scenario, then only your training will be complete. With these words, I end my talk. And in the next part of the communication, I will discuss some more salient features of communication. So thank you very much.